to the next presentation, and this presentation is on a disease that we have forgotten, or we have sort of taken for granted during this year because of the pandemic. When we now move on to dengue hemorrhagic fever, pitfalls of dengue hemorrhagic fever in pregnancy, the margin for deviation away from guidelines, and we indeed have elite presenter, Dr. Priyankara Jayawardena, who is the consultant physician at the Disoisa Maternity Hospital. Over to you, Dr. Jayawardena.
My talk is based on basically our own national guidelines and why dengue is important. When we talk about the causes of maternal death in year 2017, dengue hemorrhagic fever was the leading cause of maternal death, followed by heart diseases and respiratory diseases. So you appreciate the medical causes are the leading causes of maternal deaths now, and the traditional causes like sepsis and septic abortions and obstetric hemorrhages, the incidence are less. When we talk about the dengue hemorrhagic fever, we know the pregnancy is the number one risk factor for dengue hemorrhagic fever. In addition to that, if mother get dengue during the pregnancy and after the delivery, you know that the mother produce antibodies. These antibodies go to the newborn, and the newborn baby gets dengue. In first 6 months of life, they behave as if it is a secondary dengue. Another thing, after the delivery, if mother, a pregnant mother, after the delivery, if she gets dengue, most of the time they are on regular NSAIDs. You know, NSAIDs is a known risk factor for dengue. And when we talk about the dengue during pregnancy, important to know the clinical manifestation, but it will be the same as non-pregnant one, but the complications are more. We have to have an idea about the normal physiological changes of pregnancy when we manage dengue mother, and what happened to the pregnancy outcome due to the dengue, and how the dengue infection affects the fetus and neonate. But the management in pregnant women is not different to the management of non-pregnant adult. When we talk about the physiological changes of pregnancy, we know certain physiological changes happen in the cardiovascular system. Like in pregnancy, the pulse rate goes up. So in pregnancy, the pulse rate could be 100 even, so tachycardia. In pregnant mother, we have to think twice whether it's due to the hemorrhagic fever, whether it's due to a normal physiological change. In pregnancy, as a normal physiological change, they get peripheral vasodilatation, so systemic vascular resistance reduced, leading to reduced diastolic blood pressure. So because of the low diastolic blood pressure, the pulse volume, pulse pressure gets widened. And we know in dengue hemorrhagic fever, we talk about low volume pulse pressure. That is, if it is less than 20, we think about dengue shock syndrome. But when it happens in the pregnancy, it could be a higher pulse volume like 25. And the blood pressure is a very important parameter when we manage dengue patient. In pregnancy, there's an impact of maternal posture on blood pressure, what we call supine hypotensive syndrome in pregnancy. When the mother in supine position with a gravid uterus, venous return to the heart will be reduced by at least 30% because of the compression of the IVC by the gravid uterus. So we should know that, especially when the blood pressure is low in the supine position, we have to change the posture and check the blood pressure before taking a drastic decision. In normal pregnancy, pulmonary vascular resistance reduced and increased pulmonary blood flow with increased capillary permeability, which is pathologically important in dengue hemorrhagic fever. In pregnancy, the plasma volume expanded as a normal physiological change, and it will expand at least by 50% at the time of delivery. And the blood volume also gradually increased at least by 20%. And we know that during the labor, due to uterine contraction, some amount of blood in the uterus will come back to the maternal circulation. And after the delivery, because of the complete uterine retraction, more blood will come back to the maternal circulation. If you get a scenario like that a pregnant mother, term delivery platelet count is 10,000, and the patient is delivering, and you are going to give blood, and then you have to calculate that the amount of blood in the uterus will come back to maternal circulation. You have to have idea while giving the blood to the mother. And the pregnancy, when though when they are having dengue, they may not show the features of typical hypovolemia because they have certain physiological adaptations in pregnancy, so they may not show the features of hypovolemia like the unpregnant one. So we have to, we should know about this, and we should think blood transfusion in dengue hemorrhagic fever even with normal blood tests. And in pregnancy, when there's evidence of leaking and bleeding, when the uteroplacental blood flow is affected, the mother may not show any signs or symptoms, but fetus will show the evidence of fetal distress. So fetal distress could be the manifestation of maternal hemodynamical decompensation in pregnancy, especially in the leaking phase. So as I told you, in pregnancy maturity, the plasma volume get increased. Likewise, the red cell mass also get increased. Red cell mass could be increased up to 20%, while the plasma volume could increase by 50%. So there will be some kind of physiological anemia in pregnancy. So think about the scenario: a woman who is not pregnant and her hemoglobin is 15, PCV is 40, and for her to have a 20% rise in the leaking phase, it should be 48. So we are used to manage non-pregnant ones, so we expect high hematocrit value like 45, 48, maybe 50 when we think about leaking. But the same woman, when you get pregnant, the hemoglobin will come down to 10 and the hematocrit will be 30, and for her 20% increase will be 36. So you should appreciate the low value like 36 of PCV could be an indication of fluid leakage. In pregnancy, the white cell count will go up, so there will be leukocytosis. So the traditional leukopenia in dengue may not see in pregnancy, so it could be a pitfall. The platelet count be decreased as a part of the physiological change in the pregnancy, so it is called gestational thrombocytopenia. But usually that count is more than 100,000. But there are other pregnancy-related conditions like preeclampsia and HELLP syndrome. These conditions also the platelet count will be low. So you should understand and you should be able to differentiate the pregnancy-related conditions and dengue fever when you have thrombocytopenia. But by the time if they go to delivery, the platelet count, especially vaginal delivery, more than 50,000 usually is adequate. We know the pregnancy is a prothrombotic state because there's a accumulation of coagulation factors and the fibrinolysis is reduced and increased platelet activity. So thromboembolic complications are more in pregnancy. But when dengue occurs, the platelet count will reduce and there is a risk of bleeding and there's a possibility of consumptive coagulopathy. So if you get a kind of complicated dengue patient, pregnant one, it's a good idea to do a thromboelastometric study and get opinion from the hematologist while you are correcting the clotting factors. And serum albumin is low in pregnancy and the cholesterol is high in pregnancy, so those values are not much used in critical phase. We know in pregnancy the functional residual capacities decrease because the gravid uterus occupied the part of the lungs and the lungs will get compressed up. Because of that, the respiratory rate will be high in normal pregnancy, and because of that, there is a compensated respiratory alkalosis with high PO2 and low PCO2, which is normal in the pregnancy. In pregnancy, the oxygen consumption is elevated, and if you get a bit of acidosis, you have to correct it faster than an unpregnant one. So what happened to the renal kidney in pregnancy? In normal pregnancy, renal blood flow increase at least by 80%, and because of that the GFR is increased. And in pregnancy, they have a true polyuria. They may pass at least 3 liters of urine per day. In dengue shock syndrome, in pregnancy, it's part of the adaptation and physiological changes. The intense thirst may not appear despite intravascular volume depletion. So you have to be very careful. And the urine output may be normal because of the high renal plasma flow. So again, urine output may not be a good marker in the management of the dengue in pregnancy. So it's an area we have to be careful. When we go to the spectrum of infection in dengue, we know most of them are asymptomatic or maybe having simple dengue fever. But if dengue happen in pregnancy, there's a higher chance of getting or go to dengue hemorrhagic fever, or they could end up with features of or complications like extended dengue syndrome. We know how to differentiate the dengue fever and dengue hemorrhagic fever. And dengue fever basically no plasma leakage, but you can get hemorrhagic manifestation in simple dengue fever like gum bleeding and nasal bleeding, maybe a bit of hematuria. In pregnancy, bleeding PV could happen in simple dengue fever. It's not essentially dengue hemorrhagic fever. Dengue hemorrhagic fever, we know that why we call dengue hemorrhagic fever, there should be evidence of fluid leakage or there should be evidence of internal bleeding. When we talk about the fluid leakage, traditionally we go by high PCV and high HP, which will not happen in pregnancy. So you have to go by the hematocrit. So you should get the baseline hematocrit and to see whether there's a 20% increase. So the hematocrit may be as low as 36 and she may be in the leaking phase. And there are the albumin and cholesterol level. Albumin is low and the cholesterol is high, so no point doing those things in a pregnant lady. And when they have mild pleural effusion and ascites with pregnancy, you have to be little careful when you do the scans. In the natural course of dengue fever, we know there's febrile phase and critical phase and the convalescent phase. Traditionally, we are not much worried about the febrile phase and we are concentrated about the leaking phase. But when it comes to the pregnancy, in the febrile phase, high fever could be the killer to the fetus. So you have to control the temperature with regular paracetamol and tepid spongin, etc. And usually we don't talk about the full blood count in day 1 in non-pregnant dengue patients, but in pregnancy it's a good idea to do a full blood count in day 1 to know the baseline PCV. And when we get diagnosed a dengue hemorrhagic fever or dengue shock syndrome, there are parameters which are known to us, and the heme concentration is the most important thing in pregnancy. When you manage the fluid in dengue, and we know in dengue hemorrhagic fever, in the leaking phase, there's a fluid quota, and there is some kind of a fluid restriction. So fluid management is the cornerstone of the management of dengue hemorrhagic fever. And traditionally we advise the patient to drink water rather than giving IV fluid. And we should understand in pregnancy they may not be able to drink adequate amount of fluid, especially in the first trimester. So it's a good practice to start a normal saline drip. In pregnancy, how do you calculate the body weight? You go to the notes and get the pre-pregnancy body weight. And pregnancy urine output may depend on the posture, especially if they are on the supine position, the urine output may not be good, so you have to change the posture and when the patient is critically ill and try to get a good urine output and see whether the urine output is really low. And when we consider colloids or dextran, when we think about the leaking phase and patient is having low urine output, and when traditional vital signs like tachycardia and blood pressure, I told you these signs may not appear until late stages in pregnancy. So you may not get your traditional, the usual high PCV in leaking phase in pregnancy. So PCV may not be very high in spite of leaking phase. If you are having a kind of unstable vital sign, get a scan and consider dextran or colloid transfusion, and again plasma has no place in leaking phase. And sometimes we get patient transferred from some other place, hospital, or maybe with inadequate records, and sometimes we are wondering whether the patient is given lots of fluid and whether the patient has got fluid overload, especially in the critical phase. And the traditional way that we look for the fluid overload is difficult in pregnancy, because anyway some pregnant women are having generalized body swelling, so it may be normal in pregnancy, so you can't cut down the fluid. And usually when they are having respiratory distress and difficulty in breathing, rapid breathing, we think there's a fluid overload. But in pregnancy, these things could be normal because of the reduced functional residual capacity and less oxygen reserve. So we have to be very careful. When we give the blood, we expect significant amount of blood loss with the drop of hematocrit of PCV. And in pregnancy, again, because of the hemodilution, anyway, the hemoglobin could be low and the PCV could be low. And after the delivery, the postpartum period, you may get a patient, the HB and PCV may be low because after the delivery, anyway, they bleed some amount of blood, so you have to be careful, and you have to have a low threshold to give blood. Sometimes you may get a patient dengue or after during the pregnancy or after the delivery, on admission HB may be 9 or 10, and then this is not in the leaking phase. It may be a good practice to give blood transfusion before they go to leaking phase, and these things are not in our own guidelines. And this is then otherwise it may be difficult to save the patient when the patient is hemodynamically unstable. And we all know when the leaking and internal bleeding happen simultaneous, especially in pregnancy, at CT, the PCV could be normal. And why bleeding happen in dengue hemorrhagic patients? It could be due to the increased capillary fragility, it could be due to the thrombocytopenia, it could be due to the coagulopathy, it could be due to the liver failure. So those are the main causes for bleeding in dengue hemorrhagic patients. But in pregnancy, all these factors favors because of the physiological changes in the pregnancy. And in pregnancy, it's unique. There are certain situations you get in pregnancy. Suddenly you get a patient with low platelet count and elevated liver enzyme. So then you may wonder whether it's a dengue fever or whether it's a HELLP syndrome. As the management is totally different. The HELLP syndrome management is you terminate the pregnancy and deliver as soon as possible. Whereas in dengue hemorrhagic fever, you try to postpone the delivery. In HELLP syndrome, you get evidence of in HELLP syndrome, you get low HB, elevated liver enzymes and low platelet, plus evidence of preeclampsia like high blood pressure and urine albumin positive, this kind of other evidence which you should look for. And it's a good idea to get a blood picture and get a hematology opinion. And when you do the liver enzymes, both SGPT, SGOT, both will be high with high LDH level. In that case, you have to discuss with the VOG for early delivery. In dengue hemorrhagic fever, there is a history of fever, and if you do a scan, there may be evidence of fluid leakage. And if you compare the SGPT, SGOT value, SGOT may be higher than the SGPT, so then you have to be careful and try to postpone the delivery. Usually in dengue, there's no place for dengue hemorrhagic fever in non-pregnant one, almost no place. But pregnancy is a very exceptional case if the patient is going for vaginal delivery in spite of thrombocytopenia. With thrombocytopenia, or section is essential, maybe with a short shoulder presentation, or if the pregnant mother is continuously bleeding after the delivery, after giving adequate amount of blood, then you have to consider giving platelets. Dengue shock syndrome, the features, but in pregnancy they are more prone to go for shock syndrome. And other complications like extended dengue syndromes, those complications like encephalitis, hepatitis and myocarditis are common in pregnancy than non-pregnant women. Why people die in dengue? Because of the shock or maybe due to the fluid overload. Pregnancy, most of the time, the diagnosis is delayed due respect to the VOGs. The patient will go to the VOG first, and they should think about dengue and come back to the physician. And it could be late presentation, especially after delivery. If they go home, if they get pregnant at dengue at home, then they don't come back to the hospital. The blood transfusion and other management could be late because of the late presentation. When you do lab, the blood test, we know that the pregnancy HB and HCT could be low. It may be due to the physiological changes, so we have to be very careful. In pregnancy, you get leukocytosis. So one might think this is not a viral infection. The high white cell count due to the pregnancy. Platelet count could be normal, low due to the pregnancy, though we have to be careful. It's a good practice to do a CRP or procalcitonin to see whether there's evidence of bacterial infection. So if pregnant mother get dengue, so she could end up with abortion, liver failure, bleeding, or even death could happen. And dengue at the time of delivery is very dangerous. This could happen. These are not unusual hypothetical scenarios. There are lots of instances that the patient, pregnant mother, dengue, they come in that term, maybe going to deliver. We can't stop the delivery, so we manage with the VOG, and you have to. It's a kind of a combined management. Dengue at the time of delivery, it could be hospital acquired. If the patient is in the hospital for a few days, so she must have got it from the hospital, might have got it from the hospital. Another thing, if they get if the pregnant mother after the delivery, if she get fever, the obstetrician might think it's due to infected episiotomy or urinary tract infection, because during the pregnancy and after the delivery, few pusses in the urine is common. So you have to be careful, and always we should think about dengue. And after the delivery, if the mother gets dengue, and sometimes they are regular NSAID analgesics, so it could adversely affect the dengue outcome. And postpartum period, HB and PCV is low. And other thing, when they go home, and if they get dengue at home, because of the baby, their mothers are reluctant to come to the hospital. If what happened to the baby, if mother get pregnant, get dengue during the pregnancy, and there is a possibility of fetal death or premature birth. And if the mother get the dengue before delivery, and then if the baby after the delivery within 4 or 5 days could get dengue because of the vertical transmission. And if mother get dengue during the pregnancy, she produce antibodies during the pregnancy. These antibodies could cross the placenta and go to the fetus, and if it could last for 6 months in the newborn circulation. If newborn gets dengue for 6 months, because of the presence of maternal antibody, they behave as if it is a secondary infection. So dengue recovery, you know that the features of recovery we all are very familiar. But before you discharge a dengue mother from the hospital, you should know that when she go home, there are lots of social scenario. If she going with the baby, lots of people come to see the baby, and there's a social event. So mother has no choice; she has to show the baby to the people who visit home. So you have to be then mother is not given the priority. Priority is given to the baby. So we don't discharge the patient until she fully recovered. So take home messages are. Dengue, hemorrhagic fever, and medical problems are the leading cause of maternal mortality in Sri Lanka. So we physicians have a big role now. And pregnancy is a high risk condition for dengue as it affects the mother and baby. And we have to have an idea about normal physiological changes during the pregnancy. It's very important to know. And tachycardia and wide pulse pressure can mislead the dengue hemorrhagic fever, which is normal, could be normal in pregnancy. Low HB and low PCV during pregnancy and post delivery could be considered in the management of dengue patient, especially when you consider blood transfusion and giving dextra and infusion. Fetal distress could be the manifestation of maternal hemodynamic decompensation. It's important to control the fever from day one, because fever could be the killer to the fetus, and useful to have a full blood count on day one to have an idea about the baseline HB and PCV. Fluid calculation according to the pre-pregnancy body weight. And leukocytosis and thrombocytopenia may be normal in pregnancy. low albumin and high cholesterol in pregnancy could be misleading, especially if you do it in the leaking phase. Tachypnea and respiratory alkalosis may be normal in pregnancy. Fluid overload may be difficult to assess during the pregnancy because anyway they are having element of fluid overload. Blood pressure may change according to posture, so you have to be careful. Urine output can change according to posture and may not be the good indicator to diagnose dengue shock syndrome because usually they are having a good urine output. Dextran should be considered without high PCV, so you have to have a bit of a liberal idea, and blood transfusion should be considered even with mild bleeding. And we should not miss preeclampsia HELP syndrome when platelet is low and the left is high. Platelet transfusion should be considered when there's a dengue positive mother with thrombocytopenia and the delivery is inevitable. Dengue during pregnancy and postpartum period should be late diagnosis because the patient will go to the VOG and come to us, and it could be a late presentation because they don't like to come to the hospital. Newborn baby can get dengue from day 1 to day 5 from the maternal infection because of the vertical transmission. If the infant get dengue in the first 6 months, they could behave as a second episode of dengue, as a secondary dengue. And before discharge, we should consider the social situation at home for mother's safety, and we should discharge once the mother is completely safe. Thank you very much.
Thank you, sir, for that presentation. If there is fetal distress, do you encourage delivery in third trimester in a lady with dengue?
No. When you get a patient with dengue, mother, then always you should have a discussion with the family and VOG, and mother is given the priority, and mother's life is the priority. So we observe those things, but the priority is given to mother, and we are not going to encourage the delivery section or normal delivery, considering the fetal distress, mother's life, and the maternal mother is the priority. That we have to discuss with the family and the VOG. We have to come to agreement about that.
When one gives a flush of normal saline, dextran boluses of blood, are the expected changes the same, or are there any different cutoffs in pregnancy?
No, we don't get the expected changes like the rising HB and rising the PCV. So we have to go according to then you should think about the time, which grade she's in the. If she's early pregnancy, yes, you may get the expected cutoff values, but in the late pregnancy, then you don't get those things. Then you have to go with the pulse, blood pressure, urine output, and maybe doing an ultrasound scan, assess the fluid status. Then you have to take it as whole.
Are there any changes in management of dengue-related complications such as dengue myocarditis and dengue hepatitis?
No. There's no special management. We have to go through the same way, but not like non-pregnant ones. If some pregnant ones get dengue, especially towards the term, always you should look for those complications, doing an echo and frequent liver functions. Sometimes they may recover from the dengue, then they go to the HELP-like syndrome. So you should keep monitoring them. So management will be the same, but you should look for those things, doing echo and liver, checking the liver enzymes more frequently.
And we thank Dr. Priyanka Jayawardena for being with us for this simplified approach in managing dengue hemorrhagic fever.